Can I get a copy for my own social?
Yeah. If you don't, photo doesn't happen. Didn't happen. Should I start? Okay. Very good. What time is it? It is 11? 12. So sort of good afternoon. Good lunch break. Hi everyone. We have 5 more minutes?
11:55.
Oh, so should I stop talking? People are not online yet. Okay, so I'm gonna.
5-minute break.
I'll slink away. When I can't see when I see a mic. And I do. Yeah, actually. Here.
Actually, no.
Like the problem is like they don't understand how it works.
What are you playing?
Do you just like take that out of the interior?
Usually,
What part of
it's like a way of changing the way up.
Just like
There's like the same.
Yeah, so what I'll do is after the commissioner gives a couple of words, we'll invite you to come up to the podium and I'll just share it on the slide deck. That way folks who are joining virtually can see. And then we'll get the run of show.
All right. Thanks. Yeah.
Like right behind the subway. And you're like, why is it pointed at?
Nice place to be.
For me, I grew up there. I got enough of the humidity and heat. I'm ready for a change. Spanish for now here, and I'm like, oh, it's a lot. I was working on
So lovely.
It's just like me and like a whole
Okay, round two. Good afternoon, everybody. I'm very happy to be here with you today to launch the Commissioner's Grand Rounds series. I wanted to do this series. I know there have been brown bag series in the past, and we have a long tradition of bringing in outside expertise and leaders from health and public health and related fields into our agency. This is obviously a place that people want to come and be in conversation with all of you, our staff, our incredible staff. But I thought it was particularly important to do it now at this moment coming out of COVID, at a time when we've been so disconnected from one another, at a time when you barely had time to keep your heads above water in doing your work. This is a chance for us to reconnect with some of the reasons why we're here, some of the other perspectives that drive public health, some of the experts and really the far-reaching expertise that lives in all quarters of our society that impact our work, whether it's social sector, social needs, social determinants, whether it's racial inequality, whether it's mental health. The range of issues that we've laid out as our priorities as an agency have stakeholders that sometimes we don't even see, right? We're both working in the public sector, but we're also working in a very specific segment of the public sector on public health. But as we know, public health is so much bigger than the work of just one agency, and it's so much bigger than the work of just government. And so that's the spirit in which I want these Commissioner's Grand Rounds to unfold. And so this is the inaugural Commissioner's Grand Round lecture in what I hope will be a monthly series where we'll have in-person attendance. I know we have, I hope, good attendance online, and we'll continue this sort of approach. Maybe we'll have to find a bigger space at some point. But I'm extraordinarily grateful to Dr. Tom Insel for being our inaugural lecturer. I've known Tom for the better part of a year and a half, but I've obviously known Tom's work for longer. I met Tom, well, no, that's not true. Maybe several years at this stage, but I met Tom when I came into my previous job running Fountain House. And at that point, Tom had just recently left his role as the head of the National Institutes for Mental Health, where he led the NIMH for 13 years until 2015. And Tom is, I feel the way I can describe Tom is he's one of us. And why do I say that? He is someone who's dedicated his life to mental health. He's a psychiatrist, a neuroscientist by training, hundreds of peer-reviewed articles and in scientific journals around the vagaries of the mind and therapeutics and advances in the biomedical approach to treating mental illness. But over the course of his career, and as he'll talk about, and so eloquently writes in his new book, Healing, he came to realize that foundationally and fundamentally, mental health is social. The issues that plague people who suffer, particularly from debilitating mental illness, but all of us who deal with the ups and downs of managing our mental health are fundamentally social. And while there may be genetic and biological and environmental stressors that drive mental health, that unless we attack the social elements of what creates mental health, what worsens mental health, what serves as protective factors or negative risk factors for mental health, we are missing part of the boat. And when I think about that frame, and I think about the realization that Tom's come to over the course of a decades-long career in mental health and neuroscience and psychiatry, there's nothing else that you can summarize that with other than that's public health, right? Because fundamentally, so much of the work that we do is social. So much of the work that we do is based on the social determinants of health. the work that makes us most successful is often positioned on our ability to bring together both clinical systems and healthcare systems with the social drivers, the social systems that are so deterministic in shaping our health, shaping our well-being, and shaping our mental health. It's a particular thrill to have Tom here today because tomorrow we'll be launching the city's new mental health plan. I think it's something that reflects the better part of a year of work at this agency and really led by public health, but bringing together all stakeholders across city government and outside city government to align around an approach that emphasizes youth mental health, children, youth and families, serious mental illness, and our approach to addressing our overdose crisis. But in doing so, taking a firm public health approach, balancing prevention and intervention, balancing program development as well as underlying policies that shape those programs, and balancing health and healthcare and social needs. And so I'm thrilled today that Tom is here with us to talk about his journey and his experience that led him to write the book, Healing, Our Path from Mental Illness to Mental Health. And I think there's just going to be so much that's resonant with what Tom says today, with what you're going to see tomorrow in the city's mental health plan. And I think that bodes really well for the future of our work, our leadership in public health as we enter into this new post-COVID emergency era. And I just couldn't be more delighted to welcome you here to the New York City Department of Health and Mental Hygiene. Dr. Tom Insel.
Well, thanks so much, Ashwin, for that introduction. I got to say, this is really an honor for me. I was thinking while you were doing the introduction, first of all, I don't hear the term post-COVID often enough. It's nice to hear that. It's a kind of good feeling. But when I was in public service working for the federal government, at NIMH, I got very involved with DOD and started working with the Secretary of the Army around issue we were dealing with then was around suicides in the military. And he wanted me to go downrange. We were in the middle of the Afghan war. And, I had this sort of same sense that I was getting into the trenches. And I sort of feel like that with all of you as well. I have such enormous respect for what you've done, what you've been through. And in so many ways, you've been on the front lines, especially in 2020, in a way that those of us in the rest of the country, I'm from California, were just horrified to watch. And gosh, I have to say, such respect for how New York pulled together all that you were able to do, and all that you were able to teach the rest of us about how to manage one of these crises, because everybody ultimately ended up following you into the fire. So as Ashwin mentioned, my background really is more as a scientist. I was literally a bench scientist for most of my career, and then was moved into public service to run the NIMH early in the Bush administration and stayed through the Obama administration. It was towards the end of that term, 2015, I was giving a lecture to a group of advocates and family members, a public lecture, and I was showing them my kind of slide deck, which had this fantastic images, I must say. They weren't mine, but I got to borrow the coolest slides from the people we were funding, and I was running Obama's Brain Initiative, so I had all these slides of neurons firing and video and beautiful images of the genome and lesions and DNA and all that. And after I finished the presentation talking about the kind of neurobiology of mental illness, somebody got up in the room, that was actually the first question, and said, "Man, you really don't get it." I don't hear that very often. He said, "Look," he said, "I have a 24-year-old son with schizoaffective disorder, and he's been hospitalized 4 times, incarcerated 3 times, made 2 suicide attempts, and he's currently homeless. So, man, our house is on fire, and you're talking about the chemistry of the paint. And that was something I wasn't excited to hear, but I needed to hear that because it was, in fact, the more I thought about it, pretty accurate. And I should say that I am a strong believer in the chemistry of the paint. I think that's important, but it doesn't really address the urgency of the problem, which, and his metaphor for a house on fire, I thought was actually a pretty appropriate one. So that really got me started on a new path, which, as Ashwin said, sort of led to this public health approach that I've been in, mostly in the private sector, but working for a year for Governor Newsom in California as well. And so happy to share some of that journey with you. And the way I would see it actually is we've got 3 fires, not just one right now. Maybe this was less true in 2015, but in 2023, we're gonna have to deal with a youth mental health crisis, a problem of serious mental illness, SMI, and substance use disorder. And it's an interesting moment because we've got some extraordinary tailwinds to help us with this. I think we got the more federal focus and federal investment in mental health than we've seen since 1963. Yesterday, the White House had a special conference on mental illness amongst people of color. It was Susan Rice and the Surgeon General Vivek Murthy held that. It's the first time since the 60s that a president has talked about mental illness in a State of the Union. It's pretty interesting, but even beyond that, there are real commitments like we haven't seen. So not only, I put up here the 1115 waivers. I know New York's waiver is supposed to be adjudicated right about now, probably in the next month or so. We'll get a response to that. I can tell you from what we did in California and what North Carolina did before we did it, that you guys are, I think, in a very good position to get most of what you've asked for. And what you're asking for and what CMS wants these days in terms of how we use Medicaid is really different than what it has been for the last 5 decades. So in California, we write prescriptions for food, and they write prescriptions for rent, and we can do things that really redefine what we mean by Medicaid and healthcare. And pretty soon you'll be on that same path, I think, if this gets approved, which I think it will. The CCBHCs, the Certified Community Behavioral Health Centers, a massive new investment, really the first time since 1963 that the federal government has said, we're in the mental health care business. We're not just there to help the states, but we're going to lead. We're going to actually provide a national network like the FQHCs, except for people with serious mental illness, where there is whole person care and no wrong door and crisis services and everything that you want to bring together serious mental illness and substance use disorder and all of those things to support recovery. So the CCBHCs now with something like $9 billion being committed in the last year. That's going to be a big deal. It's going to be a real change, I think, absolute game changer for the United States as it rolls out. And most importantly, in the last 6 months, 9 months, it's gone from being in SAMHSA to now being in CMS. So it's an entitlement. It's no longer a grant demonstration project. It's a real deal, just like the FQHCs. You got local commitment. Ashwin mentioned that tomorrow the new agenda, the new plan will roll out for New York City. A lot of excitement about that, and I think there'll be, in many ways, the confluence of the things you want to do here with what the federal government is trying to get done, which is this more psychosocial approach to serious mental illness. We've got, as I say in the slide, lots of interventions that we didn't have before, and I think alternative payment models, which are now getting tried by both commercial and by CMS, which is really, really promising. The whole digital revolution is a big deal, and we'll talk a little bit about that in the next few minutes. And then this new crazy area of generative AI, ChatGPT, what it does for mental health, I still don't know, but it's going to change a lot of things in healthcare. I was trying to figure this out the other day, and somebody I work with in my company said, yeah, it's pretty cool. He said, I just looked at a really complex patient with about 700 pages in their electronic health record. And I just said to ChatGPT, give me a 300-word summary of what's in there. And within about 7 seconds, I had this amazing summary that would have taken me about 2 days to actually have put together. So there's real power in this, and we'll have to see how it actually plays out. There's some headwinds as well, and we got to talk about those because those are issues we're all going to have to face together. The public health emergency ends on May 11th. That means a lot of people who are currently on Medicaid are not going to be going forward. It means that some of the policy changes that have opened up things like telehealth and online prescribing, those will be restricted. So lots of changes there. We have to figure out how to plan for those. Every place I go, and I suspect that New York is no different, we face a terrible workforce shortage in the mental health space. Most people say, oh, we don't have enough child psychiatrists. Yeah, that's true everywhere. But what we're really missing, at least where I come from in California, are not the psychiatrists and nurses, although we're missing them as well, but it's people who can work in the community and who are on that front line. We're losing them to Target and Costco, and that's incredibly frustrating. Most of our counties have about a 30 to 50% vacancy rate, and that means that the people who are left behind have to do that much more work and are burning out at an even faster pace. So it's a vicious cycle. It makes it really hard to keep the workforce together. There is a crisis of not having enough, not just people, but also just institutional manpower, institutional power. We don't have the beds, we don't have the clinics, we don't have a lot of what we need. We have a very fragmented payment system and there's all a very fragmented service system. Lots of stuff to talk about with social media, but not to say that there are both the tailwinds and headwinds that we're negotiating right now. I think there is more force behind us than in front of us, so I'm pretty hopeful that we can do a lot in the next few years. Having a plan will make a big difference and be exciting to see how that works out here in New York. Let me take you through kind of what the meat of what I want to talk about, and we'll do it pretty quickly because I want to make sure we've got time for discussion. But I want to sort of lay out what is the problem as I see it, say something about where that comes from, and then talk about solutions. Very simply, this is just an example of what we're facing. About, I guess it was last week, maybe it was late the week before, the CDC came out with this new report, which they call their Youth Risk Behavior Survey. It's done every 2 years since 2011. They interview about 15,000 high school students in 152 schools around the country selected to be representative of the whole population. They ask students to fill out these surveys in a single class. And the numbers were pretty stunning. 57% of girls, high school girls, said that they were experiencing persistent feelings of sadness or hopelessness over the last year. 57%, which is stunning. You know, adolescence is a tough time, so maybe that needs to be put in context. But when you look at how that compares to previous surveys, it's a real increase from 36% just 13 years ago, or a decade before this data was collected. So both for boys and girls, there's an increase, but the big effect seems to be in girls, and that's something to really pay attention to. We've got, I think, not just for kids, but across the population, a continuing increase in what I call deaths of despair. Not my term, it comes from Ann Case and Angus Deaton, who got the Nobel Prize in Economics in 2015 for this concept that we don't often know with a drug overdose whether that was truly accidental or whether it has something to do with a sort of more subtle suicidal behavior. But if we put suicides, drug overdoses, alcohol-related deaths together, you can see these numbers which have been climbing steadily and then took a big surge during the pandemic. And it's worth kind of focusing on the pandemic for just a moment, because when you look at the numbers in terms of mortality, 1.1 million people, according to the data from just a month ago, died during the pandemic. The vast majority of them were over age 65. When you break this down, it may be a little hard to see from where you're sitting, but that bracket up at the top is the number of people under the age of 30, 8,268 deaths in 2020, 2021, 2022. So the whole length basically of the pandemic from COVID, which is a lot. But when you compare that to suicide deaths in the same age range, overdose deaths, and I won't even put in alcohol, but if you just put in deaths of despair, during the same period of the pandemic, you can see that for people under the age of 30, this has been a psychological pandemic, not an infectious disease one. Their risk of dying from deaths of despair was 15-fold higher than dying from COVID. We don't talk about this as much, but what we need to grapple with now is that while that infectious disease pandemic is, as Ashwin said, we're sort of in the post-pandemic in terms of viral exposure, this one is actually continuing to get worse. So this is our new big challenge, is on the behavioral health side. And it's not in people over 65, it's in people under the age of 25. It's stunning when you start to look at the actual numbers. It's not because we haven't cared about it. We've been spending a lot of money, but no matter how much we spend, and you can see the green is the public, on the public side, the dark bars are on the private side. Most of it is public money. And it's gone up a lot over the last decade. These are before the pandemic. And yet the outcomes are worse and worse. So we have to think this through in a smart way. I just want to give you one more sense of the financing here, because as I'll say over and over again in the next few minutes, we have to get the financing right if we're going to get the outcomes right. We know that the economic costs of serious mental illness are huge, just in terms of healthcare costs. But most of those healthcare costs are driven not by behavioral healthcare, but by the comorbidities, by the medical side of this. So the company I'm with now has been trying to study this problem to understand what are the drivers. And we've asked for the 5% most expensive patients from claims and markets that we work with. These are now, in this case, commercial. It's not that different from Medicaid. And what you can see is that if you take those most expensive patients, about 40% of them have serious mental illness. And then on the right side, that pie graph says that for those 40%, for the people with serious mental illness, what's causing that huge cost, $40,000, $50,000, $60,000 a year and up? And most of it is not their behavioral health care. It's actually the emergency room visits for asthma or for a diabetic crisis. It's the inpatient care for COPD or cardiovascular care. It's medical causes that are really driving this, because they're not getting great primary care and they're not getting great behavioral health care. Now, that's an opportunity, but it's also right now a huge deal. So let's talk about how we got here. For me, I think it's important to say that this is a public health crisis, but it's not a pandemic in the sense that COVID was a pandemic. This is a crisis of care. Yes, the problem is worse for young people. Adolescents have higher rates of depression and anxiety than they did. But honestly, the rates of serious mental illness, of schizophrenia, schizoaffective disorder, severe depression, they're probably about the same overall in the population that they were in 2019, that they were in 2009. In fact, that they were in probably 1809. I don't think those rates have changed very much. What has changed is us, is what we do for those people. So we're in a crisis, not because there are that many more people affected, at least with SMI. We're in a crisis because of our failure to care for them. I call this care. What is it? We don't have the capacity, as I mentioned before, and there's several parts of that. The biggest one being the lack of a safety net that we used to have. We don't have the engagement. And I want to loop back to this because it's a really important point. But in contrast to what you see in cancer, heart disease, diabetes, people who need the care the most are the least likely to get it here. And everybody's going to tell you that's because we don't provide access. Actually, when we have access, they still don't get care. Why is that? If you're depressed, you're hopeless. If you're psychotic, you don't think you're sick. If you're anxious, you're avoidant. The illness itself will get in the way. It's a really important issue that if you want to fix this problem, you want to put out those fires, those 3 fires, you've got to be thinking about engagement, and you've got to be thinking about quality. Because when people do get into care, you've got to make sure they're getting something that they want. So they not only engage, but they stay with it. And the system we have now ain't great for most people when they engage. There's no accountability, we're not measuring, so we don't learn from our experience to get better and better, and equity is a massive issue here. Let me unpack each one of these because I think you need to see the numbers to understand just what this looks like. We'll talk about capacity, just one example, but the lack of beds is a deal. It's a big deal here. We don't have enough beds in most parts of the country, especially for kids, but even for adults. We certainly had that when I started in my career, which was in like the late Pleistocene, a long time ago. But at that point, we had something like 600,000, 500,000 public beds in state hospitals for people with serious mental illness. About 600,000 altogether, but for SMI itself, about 450 to 500,000. Today it's less than 35,000, so it's a 95% decrease. That's been replaced by huge investments, of course, in the criminal justice system. This is an exceptional American phenomenon that we've decided that people who have serious mental illness, particularly people of color, should be in the criminal justice system, not in the healthcare system. And if you're a payer, that's great, because you don't have to pay for them. You leave it to the jails and prisons where we've already put a lot of money in and we have huge capacity. But if you're a family member or if you're a patient, this ain't great. And good luck explaining this to your children or grandchildren, because this begins to look like a really profound injustice. And again, it's a peculiarly American injustice. I mentioned engagement. What that looks like is really striking. About 40% of people who could and should be in care are getting care. And of those, only about 40%, according to NIMH, are getting minimally acceptable care that has any scientific basis to it. And there, about a third get well, a third get a little better, and a third don't seem to improve with the treatments we have today. Now, all that energy that I was expending at NIMH was to improve the treatments we have, which could take us, I call this, by the way, the 40-40-33 rule, because that's sort of how it plays out. That means that, if we get much, much better with our treatments, maybe we'll go from 6% to 7% or 8% response. Obviously, and this is why the public health approach is so important, we got to be at the top of this cascade. We've got to go from having 40% engaged to 80%, 90%, which is kind of what we strive for in the rest of medicine. But with this kind of an approach, if we just focused on the bottom part of this cascade, we never get very far. Huge issues with quality. I mentioned that before, that when people get into care, what they get is often really fragmented. One of the most, I think, egregious examples of this is when you look at what happens when people leave hospital. HEDIS, which is the quality control, quality metrics that we look for in healthcare, they actually monitor follow-up 7. How likely is it that someone is seen 7 days post-discharge? They do this because this is kind of a valley of death for a lot of people who leave an inpatient psychiatric facility, often too early, and often when they get out, they stop their medication right away. So we care a lot about making sure they're seen and there's a warm handoff. And what this graph shows is that since 2005, and it's no better as the years have gone on, there's not even a 50% likelihood that someone's going to be seen within 7 days. That is absolutely egregious. Just as an example, I show what, the numbers for the general medicine, in this case, beta blocker use 6 months after an MI were at about 90% compliance with that. So that's what we should be shooting for. I mentioned accountability. 80% of practitioners measure nothing. It's a data-free zone. We don't actually monitor who's getting better and who isn't, so we don't learn. And I want to spend a moment on this slide because it's one that is maybe the most difficult to talk about, but it's the equity problem. People with serious mental illness, if they were a minority group, would be worse off than any ethnic or racial group in the United States in terms of all these measures of social justice, life expectancy, employment, use of force by police, likelihood of incarceration. And of course, if someone with serious mental illness comes from an underserved minority group, it's double jeopardy, right? A lot of what's in those red bars is the result of people in the blue bars underneath. So it's a particularly difficult scenario that we have to begin to grapple with. We're having a long overdue reckoning around health disparities and injustice related to race. We're still not talking about this one. We're not talking about the fact that people with serious mental illness die at age 56 or 57. Of things, of just medical disorders that are entirely treatable. So that sort of health disparity, again, will be one of those things that's going to be very difficult to explain to our children and grandchildren. I'm old enough to remember Jim Crow and the sense we had in the 1950s that that's just the way it was. It's very difficult to change. Someday, maybe this would change, but it seemed impossible, even though everybody realized this is ridiculous. That's what these numbers look like. And what's so stunning to me is that we're not even aware of this. I don't hear anybody talking about it. Even in departments of psychiatry, academic departments are not focused on this. This is really a group of 14 million people who have been largely neglected and left to be incarcerated or homeless and outside of our care. Or as President Kennedy said in 1963, he said of them then, they should no longer be alien to our affections. And yet, here we are in 2023. These are numbers that I pulled out in 2022. This is not acceptable. So what do we do? What's the solution here? Well, there's a bunch, and certainly I'm a believer that technology can be helpful. What we've seen so far during the pandemic is that mental health care broadly has moved online. I don't think that's particularly progress. I mean, it has democratized care for a lot of people. It's made care more convenient. It's helped a lot of people who were seeking care and couldn't get it to find it, but it's boring in a lot of ways, and I'm not sure that it's improving the quality or the outcomes. But there's a way to do that. There is a way, well, called Telehealth 2.0, which hasn't happened yet, to begin to use technology to get more objective measures, passive measures, continuous ecological measures of speech and voice and face, and even looking at blink rate can be really helpful. Wearable data to actually measure sleep instead of just asking about sleep, and using scribes so that you don't have to spend 15 minutes after every 30-minute session writing down what just happened, but it just happens automatically. All these tools are now available, they just have not been adopted. But there are innovations really across the board. If you look at the problem statement I made before, those 5 areas, and every one of them, there's stuff we can do and we are doing. So I'm pretty excited about some of this, and I wanted to run through it with you. The capacity problem is partly just a money problem. We have to simply decide that we're going to shift funds to build things that we haven't been building. But on engagement, quality, accountability, there's a whole range of possibilities of how we can change what we do to make it more engaging, to make sure that what we're offering is what people want, and we're meeting them where they are, and that the people that we have are getting trained at a very high level to provide what is scientifically based, evidence-based care that's going to be more effective. We can measure outcomes, and I'll show you in a moment how we do that. And then I think even on the equity issue, especially on the equity issue, there's an opportunity to change the game. That's really what I want to focus on. Let's just talk quickly about the investment piece, because this is stunning to me. These bars are showing you the venture capital investment in digital health, which is something that basically didn't exist 5 years ago or even 4 years ago, and yet has just blown up. It went down a bit in 2022, but the numbers are almost $30 billion in VC investment in digital health in 2021 is stunning. And if you look at where that money's going, mental health is by far and away the biggest piece of it. That is the #1 area. Maybe not surprising, because so much of this can be done remotely, can be done through telehealth. Another way to say this is the 5 biggest mental health providers in the United States did not exist 5 years ago. Some of them didn't exist 4 years ago. So these are companies that are serving hundreds of thousands of patients today. They have tens of thousands of providers, and they weren't even on the map. I can't think of another area of medicine that's gone through that kind of a change that rapidly. This is partly all accelerated by the pandemic. The other piece of this, though, as I mentioned early on, is the change in federal investment. And all of you will know that this area of mental health has been kind of a hot potato. That is, nobody wants to pay for it. It is pretty expensive, but it's also something that's easy to just say, we're not going to worry about it, because there's no real advocacy, or there's some, but it's not very effective. So for 100 years, this was the state hospital system. It was up to the states to provide the asylums for people with schizophrenia or severe bipolar illness. Kennedy in '63 moved this to be the community mental health system, and that lasted about 1980 when Reagan said, wait, why are we in the healthcare business? Well, what's the federal government doing in the healthcare business? That's up to the states. So he killed those CMHCs, the community mental health system, but the states couldn't take it on. They'd already basically moved the money that they had in the state hospitals, which had closed. They moved it to prisons, they moved it to lots of other things. So they said, oh, it's up to the counties. And the counties, of course, could levy new taxes, which they did in places like California, but in lots of places they couldn't. And so there are lots of reasons why we've got a broken system, but this is part of it. The federal government did create this organization, SAMHSA, which was covering both substance abuse, alcohol, and mental health, completely underfunded, and often at most just able to provide sort of block grants, small amounts of funding for limited times. Center for Medicaid and Medicare Services was there to basically be responsive. So if states wanted to spend money on mental health, they would match it, but not much more. That all changed in 2019. And it changed really partly from Congress, mostly from Congress, somewhat in 2020 from the current administration, which has made this a priority. And it's pretty interesting what they've done. SAMHSA's budget has tripled in the last 4 years. CMS, which has really done very little in mental health, is now all in. They've hired a whole new team to begin to work on this, to figure out how to develop new payment models for it, how to build out the CCBHCs, a whole bunch of things like that. And this bipartisan Safer Communities Act, which was this was the gun bill that was passed right after the Uvalde massacre in June. Bipartisan really was, and it actually was written by staffers in Senator Cornyn's office, Republican from Texas. I don't know that it did much for guns, but it did a huge amount for behavioral health. So this has really led to the big expansion of the CCBHCs, moving them from SAMHSA to CMS, creating funding for schools and crisis services and a bunch of other things. So massive new infusion of federal money. Real quick on those others, engagement, quality, accountability, there's a lot we can do. Just like one quick summary, I think engagement has been addressed through democratizing care in these remote services. Basically, it's telehealth. But telehealth to provide everything from crisis intervention to coaching to peer support. There's a huge amount to be done there. This ability to improve quality by monitoring what goes on, capturing data that really allows you to look at how you're doing against specific quality metrics, super helpful. And then measuring individual response rates through wearables, through what we call digital phenotyping, which is really capturing how somebody's doing objectively, not just by asking them how they feel, but actually, or how you sleep, but actually by measuring sleep in a way that we know how to do with a Fitbit, or being able to use natural language processing when somebody's talking to be able to get a really good sense of the velocity, the content, the sentiment, the coherence, a whole bunch of things that really matter to us as clinicians, to what we do on an individual basis, but we do it subjectively, we do it, I would say, inconsistently. We have tools now to do this much better. The key thing here is to create this kind of learning engine, this idea that we can have a feedback loop. So as we do interventions and we're capturing the data, we're learning what's working, what isn't, and we're improving. We do this in diabetes pretty well. We do it in treatment of hypertension. We have not been doing it in mental health. And it's one of the reasons I believe why our outcomes haven't gotten better. While we're spending more and more money, outcomes just don't reflect that. Last thing then is around this equity issue. And this, as I said before, is in some ways the most painful thing to talk about because the data are so damning. It's such an indictment of us as a care system. And that's why I feel so strongly we need to focus on it and make sure we don't leave this one for our kids to fix. I was thinking about this when I was working on the book, Healing, and I was fortunate to, Governor Newsom allowed me to sort of go around, not just California, but around the country using his name to have an in with people, which was really effective because nobody wanted to talk to me, but they always wanted to talk to somebody who represented him, even if it was just a complaint. And so I was on Skid Row in Los Angeles and met with a street psychiatrist there, a very, very gifted guy. And I was asking him about this whole inequity problem. And he said, the problem is the model we have. The medical model isn't working. We need a recovery model. And I said, all right, what do you mean recovery? What is that? And he said, it's just the 3 Ps. It's really simple. It's the 3 Ps. I thought, oh, you got Paxil and you got Prozac. And he said, no. It's place and purpose. That's what we're missing. People, place, and purpose. We don't do that in our clinics. We don't do that in our hospitals. But if you talk to the people around us, people we're serving here, that's what they're missing. Social support, a safe environment, and some reason to recover. Something to get up for each day. Thought a lot about that, and I realized, A, we used to do that a lot better than we do it today, and B, we know how to do this. It's not that hard. It's not like needing an mRNA vaccine for COVID. The things that give us people, place, and purpose are, we have clubhouses. We can create, family supports that are really important for this. Housing, supportive employment, all of this stuff has been around for decades, but we don't do it. Now, why don't we do it? Pay for it. The only one of these that gets paid for is the medication of primary care, maybe some cognitive remediation psychotherapy that you can bill for. There's no CPT code for a clubhouse. There's no way that for most of these services, you can actually get it paid for. Now, the exciting thing is that the new waivers are beginning to make that possible. And all of a sudden, you can start to use Medicaid for housing and for all 3 of the Ps, actually, including clubhouses, we're hoping. So that's actually a good sign. The company I'm in now, Vana Health, which is just getting started, is making the argument that if we change the way we pay, which is our 4th P, we can actually begin to cover this. And it's taken me a long time to realize that part of the pickle we're in mental health care is really, it's the system we pay for, is the system we have, that we're essentially incentivizing all the bad behavior and all the failure by having what's not a healthcare system, but a sick care system. We're actually paying for the clinics and the hospitals and the medications, but we're not paying for the things that you need, the 3 Ps to actually help people recover. I'll finish up by saying that when you look at this, I think you have to realize, and this is sort of the public health mantra, that if you care about health, you have to care about more than health care. People who are really thoughtful about this, like Michael Marmot and Don Berwick and many others have, I got this slide actually from Don Berwick, have pointed out that when you look at the predictors of health outcomes, that is well-being, longevity, those kinds of health outcomes you care about, only about 10% of the variance is explained by clinical care. Most of it is really due to other factors, health behaviors, social and economic factors, all the other things on this pie graph. We're spending $4.3 trillion, 19% of our GDP in America, on that 10%. The rest, we leave it to, it's for bake sales, it's philanthropy, it's charity, it's done by nonprofits. And I think we gotta ask ourselves, is that the right model? Is that really the way we want this to be playing out? And is that why we're in the situation we're in? And I'm gonna argue that it is exactly, that we're spending a huge amount of money on the things that are giving us some short-term gains, but not really recovery. And it's the medical model, which I think has not served us well. Now, I'm going to argue that we need a medical model here. I actually firmly believe that mental illnesses are brain disorders, and they deserve all the same rigor and research and reimbursement as any other medical disorder. The problems are indeed medical, but the solutions, as Ashwin said at the beginning, are social. They're environmental, they're political. They're the 3 Ps. They're, people, place, and purpose. That's where we need to go. We need to think about this with this recovery model. And by recovery, I don't mean the 12 steps. I mean really thinking about this as the 3 Ps, which is way beyond symptoms. And it's way beyond the way we define healthcare today. And I'm super excited that in places like California, we are redefining healthcare to include all 3 of these Ps. And I think you'll be there as well if your waiver gets approved. That'll help you to move forward a lot. Just finish up with this one point, that on each of those areas of pain, the youth behavior, mental health, SMI, and SUD, I think we have very specific things we can do going forward. What we're trying to do in California, and I think it's something you'll pick up here, for youth, the youth mental health crisis is really moving to have schools as our center of gravity for mental health care. So we're creating a whole new workforce to work in the school system. We don't call it this, but it's essentially future-proofing the next generation, giving them the tools for resilience, for understanding how to do emotional regulation, understanding how to support each other, using technology when that's appropriate, all of these things. The ability for, and I know you have this now in New York, for any person in a crisis to get telehealth consult, primary care docs getting to specialists, taking a risk-based approach, which has been really valuable in some places. And then EPSDT is part of the Medicaid plan, which we don't talk about enough. One of the reasons we don't do prevention in most places is because you have to have a diagnosis to get reimbursed. EPSDT allows you to get around that. These are, I kind of forget how this goes, early screening and early and periodic screening, diagnosis, and treatment. So it's something to think about as you go forward, particularly for youth mental health. SMI, mentioned clubhouses, a psychosocial approach, using digital tools, super important. Thinking about early intervention with coordinated specialty care, having a really different kind of payment system that looks at value, not just at volume. So you're paying for results. You're actually giving people the funding in the community to be able to give the services that someone needs and not have to worry about documenting every 15 minutes in a fee-for-service situation. In SUD, there's a lot already going on here around harm reduction, being able to integrate the data from the SUD world and the mental health world and the medical world is hugely important. Thinking about a recovery and medical model together, which we've done a very poor job of. And then building community, which is really an issue for all 3 of these areas, but particularly in the SUD space. So what did I tell you? We're in a crisis. It's a crisis of care. We have solutions for almost every part of this. Oops, sorry. Go back here. The recovery model really helps us to bend the curve in a way that the medical model, I think, hasn't. And just the mantra I have is that the problems may be medical, but the solutions are really social and even beyond social. They're environmental. They're even political. So people, place, and purpose. So that's really the message I wanted to send. I hope we have a few minutes for questions. I'd love your thoughts and love your questions as well.
Thank you, Tom. Oh, is it on? Great. Thank you, Tom. That was a whirlwind and a really lovely overview of some of the challenges we face in the public health crisis of mental illness. I'll start with a question or two, and then I want to make sure the audience has a few minutes to ask questions as well. So often, and when you have just huge amounts of structural gaps in access to care, so much of how we frame the discussion is, can I get care when I need it? And I think anyone who's ever tried to get mental health care in this city or in this country realizes it's too hard for everyone. but it's especially hard for people of color, it's especially hard for lower income folks, people who have been historically left behind, it's especially hard for people with SMI. So how, when you think about this conversation around access to care, I mean, fundamentally, one could argue that a lot of what you're talking about is access as an umbrella, because you want people to get what they need when they need it. But here at the health department and in public health agencies across the country, we also think about prevention from the perspective of how do we go even further upstream. When I think about SMI, I think about early intervention programs. I think about catching people at first or early episode psychosis. How do we think about also making that a part of the thinking? Because when you ended with that pie chart, which we know very well in this department and in public health, the contributor of clinical care to overall health and well-being, what we see is a lack of will, political will, to really invest in the things that are going to deliver the greatest return on that investment. So how do you think about that prevention problem, thinking even further upstream?
Yeah, so there's a lot there. Let me push back on a couple things. One is, I'm not sure how much is an access problem. There is certainly an access problem. So when you're looking for care, getting the care you want when you want it can be really difficult. That is a place where technology is helping us, and I think having these startups that are now bringing in thousands of therapists who can represent every ethnicity and every language that you might want, and giving people the choice in real time to find somebody, if not within 20 minutes, certainly within 24 hours. That's a new game, and it's it's a little bit like Amazon. All of a sudden you've got mental health care with convenience, which we've never had. There are real issues for me on quality, on how that really plays out. Even getting it paid for is still an issue, but it tells you where we could go and what we might be able to expect. I still maintain that, particularly for the people that we serve, a bigger issue is engagement. Every community I've gone into in the last month, I've been in Massachusetts, Pennsylvania, multiple places, Arizona and California. When I look at the population they're supposed to serve and how many people they're actually seeing, the number is never greater than 30%. So there's 70% of the people out there who we just don't get to, and they end up getting into the system when they're in crisis at a very late stage, when they go to the emergency room and often end up in an inpatient facility, and those are the people that cost us $60,000, $70,000 a year because we didn't spend $600 or $700 a year reaching out to them to make sure they were seen by a coach, getting involved with a clubhouse, that they had the 3 Ps, all of which is not that expensive to do. So I think in response to, what's the conversation to have politically, you can just talk about the money. You can just say, look, you want to save money and get better outcomes, you move upstream, because the way we do this now is the most expensive, the most intensive, and the least effective way to provide care. And it doesn't work for anybody. Nobody likes this system, except maybe if you're a hospital and you can bill for it and you get paid. So, but they shouldn't be the center of the system, right? That's not who your customer is if you're in the public health space. So I do think we want to change the conversation in that way and to help people to understand that there's an economic, because it's taken me forever to understand this, but in the United States, like it or not, healthcare is fundamentally a business. It's just a business, and it's like any other service business. You got to make a business case if you want to change anything. You've got to either save time or money or both. And I think we can do that by providing the kind of early stage, upstream kinds of supports. The last thing I'll say about this is that one of the things that gets in the way is that for most of healthcare, because this gets paid for with healthcare dollars in the United States, nowhere else, but here it does, you need a diagnosis. And so it's hard to do prevention if you need a diagnosis. You can do vaccines without a diagnosis, but it's pretty hard to get healthcare dollars to pay without a code that's based on a diagnosis. So the reason I put up thank you. is because that does give you an out, and it's one that we've used in California a lot, to be able to provide services in schools and still get paid for them. You don't get paid a lot, but it is a way of using Medicaid money, and it's something to think about, because we need to build on that precedent that says you don't have to be sick to get care.
Right.
And it's that fundamental flaw in our system that leads to everything else we're talking about.
You're in a room full of public servants. You've been a public servant yourself, but I did notice, and it's clear that you think there's a really strong role to play for the private sector in growing and improving our mental health system. That, in all honesty, isn't something we do that well, right? As the public sector, forming private partnerships, public-private partnerships in health is not exactly something that we have a long and steady track record on, especially when it comes to building the foundations of a system. But it's clear you have a point of view, and the numbers support you in terms of where the investment's coming from, that the private sector has a really strong role to play in partnership with the public sector. Can you say a few words about what you think that looks like and why?
You use the key word, actually. I think it's partnership. I learned a lot with COVID. If you go back to those early days, what was so stunning was the way the public and private, and I would include academic, government, and private sector, got together. They got rid of all the red tape. They said, urgent crisis, all hands on deck, we got to get this done. And they did it. They did it for clinical trials, they did it for vaccine development, they did it for diagnostics. And it was stunning. We've never seen anything like it. But that, for me, was the proof that of what we could do. I was just thinking about this, because if we said that, the youth mental health crisis is that serious, that losing, 240,000 kids or 140,000 kids over the course of 2 or 3 years is not acceptable. And the fact that it's getting worse, not better, we want to bring all hands on deck. That's, I think, how we want to do it. You want to bring in, you might even bring in, social media companies that are really good at engagement. They're too good at engagement. That's the problem. TikTok is just dangerous, but they know how to meet kids where they are. That is where kids are. And so thinking about how do you bring all of this together in some way, some new way, so they're no longer part of the problem, they're part of the solution. You bring in government at the same time. You bring in the academic sector that's got a lot of the scientific power to bring to the table. I think that's increasingly, and the message, the lesson from COVID was that's how you get stuff done quickly and done well if you're serious. Bluntly, the public sector, especially the nonprofit sector, is under-resourced. They just don't have the capital, they don't have often the talent, they don't have the technology. The private sector has got its own set of problems. They do have all those three things, but they may not really understand the problem in the way that the public sector does. They don't have the community, they don't have the relationships and the diversity and all that stuff that you really need here. So it's bringing those together and playing off the strengths of each that I think has the most promise. We got to figure out how to do that. We aren't doing it anywhere that I can tell. It's very hard. My company Vana is trying to work with. Just today, we've been trying to work with the city of Philadelphia, and we were told this morning that, oh, you know what? After 9 months of negotiating, I think we need to do an RFP. So let's stop. We've actually hired all the people ready to go. Then let's stop and start over again. And maybe in about a year, we'll be ready to get started. So there's just, real difficulties with bureaucracy and the tape, and just no sense of urgency in so many of these agencies. We've got to figure out how to break through on some of those things.
Well, I think you're in a place that has all of those things in spades: urgency and commitment and focus. I think we've done incredible things during COVID in particular, but for decades. So what's kind of a few words that you might have towards the team here, the public health staff of the largest city in the country, the largest health department in one of the largest health departments in the world, with, I think, a unique ability to, and sometimes a unique freedom from some of the challenges that other public agencies face, which is that we've got incredible resources, incredible talent, and the ability to think innovatively, because this place, this department in particular, but this city has really led the way on so many fronts. What are your thoughts?
Yeah, well, I do think that you're in a very important role here. Really, it's an opportunity, and with the new plan coming out, this is the moment. I guess my main message here is one of hope, but also one of urgency. You know, I do think that there's a lot we can do. We know what needs to be done. We know what the problems are. This isn't an R&D problem. This is an execution problem. This is figuring out how to get the job done. And that job is in terms of building out the psychosocial supports for people with serious mental illness, building out the programs within the schools and for families, for the youth mental health crisis, and of course the harm reduction piece, which you're already deeply into for SUD. But if you put all those together, a big piece of it is building community, building that social fabric that's missing. And so my message is, we can do this, but it needs to be done yesterday. I mean, this is incredibly urgent because these problems are getting worse, not better. And we can't just continue to do what we've been doing. So we're going to have to figure out how do we move the needle much more quickly, who do we work with, how do we change what we do to be able to get better outcomes.
Well, I know we're out of time, and I apologize for not getting to audience questions. We'll make sure that we do that next time, but I want to respect everyone's 12 o'clock hour. I know you have meetings to go to, but look, I don't think there could have been a more important time for you to come and to launch this series. Tomorrow we launch our city's mental health plan, as I started with, and the pillars that Tom described are exactly the pillars that we're focused on. And I think, much as you outlined, we have a lot of the solutions in hand. It is about generating the coordinated investment and political will to grow them. This health department runs so many of the programs that you mentioned are critical to the recovery model for people with SMI, but also for young people and for people using substances. And so we thank you for being here. Thank you to everyone here who came out for this lecture. Over 800 people between here and online are watching right now. And I can't think of a better way to have launched this series. Really deeply appreciative to you for your work, and please stay in touch with all of us.
Absolutely. I look forward to following your progress. It's great to be here.
Thank you. Everyone will be announcing the next speaker of the series.
Thank you. Thank you.